You want the truth? Well, you've come to the right place because we have Dr. Peter McCullough on today's episode, and that is what he is all about. He is one of the lead experts on COVID-19 currently in the world, and his main mission is to share the truth about treatment, the vaccines, and COVID-19 in general. So without further ado, Dr. Peter McCullough on Faithful Freedom with Taryn Gregson. Freedom is non-negotiable. Mandates, free speech, cancel culture, parental rights. These are real people that have stood up for their freedoms no matter what. Welcome into Faithful Freedom with Taryn Gregson, presented by We the Patriots USA, helping everyday Americans defend their God-given rights. Dr. McCullough, you have become one of the leading experts in the past 2 years here on COVID-19. And I want to start off with the hot topic right now, the Omicron variant. Should we be concerned about this? How does it vary from the Delta variant? What do we need to know?
Well, Taryn, thanks for having me on the show. And as introduced, I'm Dr. Peter McCullough. I'm an internist and cardiologist, as well as a trained epidemiologist. I'm trained to study these sources of data. I'm in practice in Dallas, Texas. I just finished at the hospital today. So I spend about half my time in clinical practice, half in scholarship. I'm an author, I'm an editor, and I'm now in the last 2 years in COVID-19, a major media commentator and analyst. I have testified in the US Senate, multiple state senates. And so far, through a series of opinion editorials last year on the Hill and my testimonies, and this year on America Out Loud Talk Radio, the McCullough Report, I've correctly predicted all the twists and turns of the pandemic. So I don't want to be wrong on this. And so with Omicron, the most recent variant, I'm just going to read for your listeners the update from the Center for Disease Control, MMWR, the Morbidity and Mortality Weekly Report. That's their journal, December 10th, 2021. The CDC told America that they had data available for 43 cases in the United States that the ages ranged between 18 and 39. There was 58% of cases were in that age range. Importantly, 79% of cases occurred in persons who were fully vaccinated. And the most common symptoms were fatigue, congestion, runny nose. One patient was hospitalized just for 2 days, and it looked like it was, reading into that, probably a panic hospitalization. It wasn't needed. And so far, no deaths. Now, worldwide, we have heard of a death. I'm not sure if that can be confirmed at this point in time, but we have information out of France by Dr. Fantini. This is by personal report, not yet published, where modeling was done. And the modeling is to basically try to predict what's going to happen. So once the sequence of code is known for Omicron, we'll get into that in a minute. Once the sequence is known, computer models can predict what's going to happen. So it's based on how the virus infects the body through the ACE2 receptor. And so Dr. Fantini's work out of Marseille, France, by personal communication, indicates, to give the listeners a background, that the what's called the transmissibility index of how infectious it is, the transmissibility index of the original Wuhan wild type virus was between 2 and 3. The transmissibility index for Delta was over 10. And the transmissibility index for Omicron is coming in between 4 and 5. So it's going to be less transmissible than Delta, which is good. I think Delta has been very hard. The Delta outbreak, as many of you know, has been our longest and most difficult outbreak because Delta is at least 5 times what the original epidemic was for the United States. The United States, it didn't spread that fast, that hard. Delta has been very, very challenging for us. And so that's what we know regarding Omicron. Now, in a paper, there's already been a preprint paper that came, excellent group collaboration out of a company called Inference in Boston, and they collaborate with the Mayo Clinic. This preprint just hit the news wires, and the first author is Venkata Krishnan. The senior author is Soundarajnan, and it's from Inference Labs in Cambridge, Massachusetts, as well as one of their offices in Toronto. They are a sequencing company. They have basically described the sequence of Omicron. And what we know here is Omicron has 30 mutations in the spike protein. 26 of them are brand new, unique mutations in the spike protein. There are 10 in the receptor binding domain. That's the outer segment of the spike protein that actually can bind with the human ACE2 receptor. Of those 10 mutations, 3 are insertions. 1 is a deletion, which is interesting. And I'm sorry, 3 deletions and 1 insertion. And what we've learned so far is that it's almost, this is so mutated, far more mutated than Delta. Delta only had 7 unique mutations. Gamma had 8 unique mutations, and Alpha only had 4 unique mutations. Beta had 6. That what Venkatakrishnan is pointing out is that almost as if this is an evolutionary mistake, that somehow through recombination, the virus replicates and it can make a mistake. This one basically became a mistake. It has some code that looks like it's not code for the original spike protein. So it's almost as if maybe there was a fusion with a respiratory syncytial virus or some other virus where it may have picked up some genetic material. Having said that, it was discovered on the border of Botswana. Some healthy travelers tested, and there was an unusual pattern in the PCR. The PCR, the polymerase chain reaction, uses 4 primers that look for little strands of base pairs of RNA code. And the 4 primers are the spike protein, the nucleocapsid, the envelope protein, and the polymerase. And interestingly, these young travelers crossing Botswana had what's called S gene dropout, meaning the PCR couldn't see the spike protein primers because the spike protein had mutated so much. So that's what actually tipped people off that something unusual was going on. And that's how Omicron was described. I was called on national news, I think within 24 hours. And I told America at that time, it looked to me like this is an evolutionary mistake, meaning that the virus typically mutates to become more transmissible and as opposed to less transmissible. And it usually doesn't make this jump in the number of mutations. So it's not enough to jump phylogeny. This is not SARS-CoV-3. It's still SARS-CoV-2, but it's heavily mutated. And while we'll try to look at forecasting, I'm basically going to forecast it's going to carve out an ecological niche like epsilon and like lambda. These have also come along, but there doesn't appear to be anything that can supplant Delta right now. Delta is so successful in the vaccinated, and it is so contagious that I think right now it's Delta is here to stay until we see more data.
Why is it that we are seeing so much of the Delta in the vaccinated? Is it because of these mutations that you're talking about?
Delta basically has learned to thrive among the vaccinated. And in key papers, one by Neeson from the Mayo Clinic and this company Inference, they looked at the data and it was clear that once we get to 25% of a population vaccinated, we will basically create an environment where a dominant strain will move forward and hyperdominate the field. There should always be a blend of strains because the virus makes mistakes and it replicates, and diversity is natural in nature. Diversity is natural. What's unnatural is to have a single hyperdominant strain, and that's what's happened. The unnatural part of this viral epidemiology, and basically, we're walking viral evolution right in front of us. The unnatural part of this is what's been forced by mass vaccination. Experts have said, don't mass vaccinate the entire world with a very narrow, non-sterilizing form of immunity, because it's simply going to allow a superbug to dominate. And that's what's happened with Delta. Now we have 9 studies. 9 studies show that Delta thrives in the nose and the mouth of the vaccinated, just like it does in the unvaccinated, at very high and equal viral loads. A paper by Rai Marisma showed this from the Wisconsin Department of Public Health. In fact, high viral loads and actually equally as infectious in the in vitro models. Acharian from University of California at Davis had shown that. We had data from Chow and colleagues, a unit from Oxford out in Ho Chi Minh City. They described fully vaccinated healthcare workers in a lockdown situation, basically a dormitory setting within a hospital. These healthcare workers had just taken the AstraZeneca vaccine. They were perfectly vaccinated, and they were passing Delta to one another. And actually, they were studying the sequences. They knew who passed it to what. Now it's clear in a paper from Singarajanan that was published in Lancet. This analysis was a case contact tracing analysis, and it clearly showed that, and the first author, I want to pronounce her name correctly, Annika Singananagamam, in Lancet, published, the title of the paper is Community Transmission and Viral Load Kinetics of SARS-CoV-2 Delta. She demonstrated with her group that 39% of all transmission is from fully vaccinated to fully vaccinated. So this must have been what happened at Duke University. You know, the kids came back from summer at Duke University and there was an outbreak. There was about 300 college kids who developed COVID-19. And I think all but 8 of them were fully vaccinated. They must have been passing it to one another, the Delta variant.
And we're also seeing this. I come from the sports world, was a sports broadcaster, and we're seeing this a lot in sports too. You know, they have had vaccine mandates across all of these major sports leagues across the world. And now everyone's testing positive for COVID. And, you know, I've heard you talk about it too. So part of it's the Delta variant, but part of it's also, you know, testing and some complications around that.
You're right. So everybody who's a sports fan out there, when they hear about their next favorite player being positive for COVID-19, the first thing they should ask them is if they're sick, because there's so much unnecessary testing going on in sports. Remember, the FDA has never approved PCR or antigen tests for asymptomatic people. The World Health Organization says as of June 25th, don't do it. Don't do asymptomatic testing, because all it does is generate false positive information. And the CDC doesn't provide any endorsement for that in asymptomatic individuals. So the NFL Player Association, the NFL, the league, and the owners, college football, NCAA, they are all out of bounds. They're not even following any advice from regulatory authorities. It's a complete overreach. And so what they're probably doing in many cases is generating a lot of false positives. We're not hearing about players or coaches ending up in the hospital with COVID-19. Thankfully, we haven't heard of any COVID-19 deaths. I think we're just generating a lot of false positives and then creating a lot of worry. Some people are being fined because they didn't take the vaccine. Other people are sitting out, doing more testing. What they really need to do in the NFL is they need to figure out who's had COVID-19. Those people ought to be the A team. They can't get it again. So they need an inventory and who's had COVID-19. These are young people. Probably the majority have had COVID-19. Now it's over with. And those who are still susceptible, they ought to be watched for symptoms. And if they have symptoms, they should come forward for testing. So I can tell you, as I laid it out, the strategy for COVID-19 in professional sports ought to be a lot simpler. It should be much more onerous, and it would protect the players and allow things to move on.
We're seeing that also in the private business world too. You know, these vaccines are mandated. Testing in a lot of cases is required, you know, whether or not you're vaccinated, or if you're not vaccinated, the testing's required, masks are required, all of these different protocols and these responses right now in the environment that we are living in. What's your response to those? Are those viable? Do those work?
We should never do testing for non-medical reasons. So many of your listeners know I just was on Joe Rogan this week. I did the trip down to Austin, and you know, one of the things, Joe's had COVID-19. I've had COVID-19. We showed up there. What did we have to do? First thing, we both had to take a test. I said, Joe, we've both already had it. Why are we doing a test? We can't get it a second time. And he said, well, you know, we have insurance and we have protocols. It was all for non-medical reasons. We should never do tests, and we should never take vaccines or take medicines for non-medical reasons. I mean, that ought to be something very clear. The only medical reason to do a test is if somebody's acutely sick and still susceptible to COVID-19 in order to make a diagnosis. They are EUA approved. Actually, some of the PCR tests are fully FDA approved, but they're approved as diagnostic aids in an acutely sick doctor diagnosed COVID-19.
And what about those with natural immunity? Why all of a sudden has, you know, the decades long science on natural immunity sort of been thrown out the window for all of this?
Well, it hasn't. We have over 135 studies now that show that the natural immunity, once somebody recovers, that it's robust, complete, and durable. We know that SARS-CoV-2, the current virus at issue, is 90% homologous to SARS-CoV-1. With SARS-CoV-1, there was never an issue. Nobody ever got it a second time. It's one and done. And so when we look through the literature and we put up a stringent definition of someone, having 2 episodes more than 6 months apart, with PCR positive at a low cycle threshold, with confirmatory antigen and limited sequencing, there's never been a second case with any type of stringent definitions. The only thing that's happened is people think they have it twice because there's all this unnecessary testing going on, and we're generating lots of false positive testing. Some people come forward for testing and they have a cold, but the COVID test is falsely positive. And they said, well, I had COVID 6 months earlier. So I think at this point in time, there's basically there's a false narrative out there that one can get COVID a second time or get COVID in a indefinite number of times. And people should look around them and ask themselves, are the nursing homes being emptied out month after month, year after year? Are the seniors going on the ventilator over and over again? The answer is no. It was obvious. It swept through the nursing homes in the first year. It's one and done. Our seniors who are now naturally immune are fine. People ought to just use common sense and understand that if it was possible to get COVID-19 a second time, we would have seen hundreds and millions of cases worldwide, and we haven't seen it. In fact, our CDC has basically admitted they've never seen a second case of COVID-19 where someone got it a second time and transmitted it. At the same time, our CDC has on file through October 18th, they have over 41,000 full vaccine failures. I mean, people who are fully vaccinated, reported through Departments of Community Health, and they've either been hospitalized or they've died. And so these are very serious definitions of vaccine failures. We don't have a single case like that of natural immunity failure.
Taking a quick break to encourage you to head over to WeThePatriotsUSA.org. This is how you can get directly involved in sharing the truth, fighting for our freedoms, and sticking up for medical freedom. Hit that donation tab on the homepage. Your tax-deductible gift will assist this 501c3 organization working to protect your religious freedom, medical freedom, parental rights, educational freedom, First and Second Amendment freedoms, and so much more. Head to WeThePatriotsUSA.org now. Now back to my discussion with Dr. Peter McCullough. And then for someone like me personally, I was told I had COVID, I'm pregnant, I should still, despite all of that, get the vaccine and get tested regularly, all of which you just debunked and said that's not necessary. So let's talk about the risk factors. There's always risk factors that people have to weigh when it comes to any sort of vaccine, but particularly this one. And what are your thoughts on it being recommended to pregnant women in particular?
We know that the registrational trials that Pfizer, Moderna, Johnson & Johnson, and outside the United States, AstraZeneca performed had really strict criteria. The clinical trials were done correctly. And recall that the clinical trials delivered pretty good results, including 90% vaccine efficacy and acceptable safety. So the clinical trials were done the right way. And one of the reasons that made it come out so good is they properly excluded groups from the clinical trials, including pregnant women, women of childbearing potential, COVID recovered, and suspected COVID recovered patients. That was correct. We always have exclusion criteria for clinical trials based on principles where if we believe a group has an expectation of not benefiting from being in the clinical trial or an expectation that they're going to be harmed, they're excluded. So routinely, pregnant women are excluded from clinical trials because pregnancy is actually 2 patients. It's the mother and the baby. And so we must have a lot of supportive, assured, basically reassuring data before we would ever use a new product in a pregnant woman. For vaccines, the only vaccines that are allowed are the inactivated flu, pertussis, and the a tetanus shot. That's it. So we never allow a live vaccine or even a live attenuated vaccine in a pregnant woman. And we would never allow a vaccine that has a dangerous mechanism of action into a pregnant woman's body. And what we know of the COVID-19 vaccines is they install genetic material that's carried on lipid nanoparticles into cells throughout the human body. We know now that the lipid nanoparticles install genetic material in the brain, in the heart, in the adrenal glands, the ovaries, the testes. This is now known. And there, the genetic material basically takes over cells' machinery, and the cells produce the spike protein, the dangerous protein on the surface of the virus. There's little spines that you see on the cartoon. Spike protein is 1,200 amino acids. It's got about a dozen glycosylation attachments. It is lethal to cells. It damages cells. It goes out in the body. It freely circulates. It damages blood vessels. It causes red blood cells to stick to one another, platelets to stick to one another. It causes blood clotting, and that blood clotting causes damage to organs like the brain, the heart, and elsewhere in the human body. So with that description, I can tell you that no reasonable doctor and no reasonable pharmaceutical company and no reasonable, governing body over doctors and public health would ever let a pregnant woman receive an injection of one of these COVID-19 vaccines. No good doctor would. And the FDA was correct in excluding pregnant women and women of childbearing potential from COVID-19 vaccination.
But yet they're still recommending them. And, I've also heard, you give data and talks, about how COVID-19 is, not really affecting children, but yet they're pushing forward with possibly mandating vaccines for them. Why do you think that there is such this big global effort and coordination behind all of these things?
You pick two populations. Let's take pregnant women first. Pregnancy is a natural, very strongly immune state. Pregnant women have some of the best immunity you can find in human medicine. You know this because as the baby moves through the birth canal, there's actually a tremendous exposure to bacteria in the bloodstream, and pregnant women do fine. It's basically a God-given miracle to deliver a healthy baby and having a wonderful family start from there. And it is a super immune state. So pregnancy is not an immune deficient state. And in a paper published in the Annals of Internal Medicine by Pinellas and colleagues, pregnant women have a better COVID-19 outcome than non-pregnant women. So we don't have any concern with pregnant women. Now, there are some pregnant women who get COVID-19, the respiratory illness, and they have severe symptoms, or they may have risk factors like obesity or diabetes. They may have intrinsic lung disease. And so we are skilled in treating pregnant women. Pregnant women have received monoclonal antibodies, the Regeneron, the Lilly, or the GlaxoSmithKline product. They weren't tested in clinical trials, but we don't have reason to believe the monoclonal antibodies would be dangerous. We can clearly use hydroxychloroquine, which is modestly effective. Hydroxychloroquine is routinely used in pregnant women who have systemic lupus erythematosus. There's been studies of hydroxychloroquine in pregnancy. It's perfectly safe for the mom and the baby. So we can clearly use hydroxychloroquine. We don't have such supportive data for ivermectin or favipiravir, and we don't have data for the new Pfizer drug, nalfipranir, combined with ritonavir or with molnupiravir, which is the Merck drug. But we have data with azithromycin, which we had used in our protocols. That's fine. Inhaled budesonide is fine. Oral prednisone is fine. Aspirin in pregnant women is fine. In fact, it's used in preeclampsia anyway. And then there are circumstances where we may need to use blood thinners in pregnant women. But I can tell you, I'm very confident that skilled doctors can treat pregnant women with COVID-19 and deliver them through the illness without any threat to the woman or the baby. The only women that I'm aware of with pregnancy that's actually had a bad outcome or fatal outcome are sadly those who are denied treatment. They are denied treatment by clinics and hospitals. And it's a shame. Now, the guidelines bodies, the American College of Obstetrics and Gynecology is actually officially recommending that pregnant women actually take the COVID-19 vaccines. And that means they're recommending them to go into research against their will. So remember, the COVID-19 vaccines are research. None of them are FDA approved. The consent forms always say it's experimental or research. So never have we had an official body, the American College of Obstetrics, basically provide a recommendation that women be conscripted into research with a vaccine that doesn't have any proven safety in pregnant women. In fact, there's only one paper. The first author is Shimbawako, and this was published in the New England Journal of Medicine, and it involved about 3,000 pregnant women. And in that paper, they did take the COVID-19 vaccine. It's ill-advised in my view, but they went ahead and did it as part of the public program, and things were basically chronicled. There was great controversy in what happened in the first trimester. The first trimester fetal loss rates could have been as low as 12%, but depending on what denominator was used, because not for the full course of 9 months, that fetal loss rate could have been as high as 83%. Cool. So there's a huge range, and there was a ton of letters to the editor that came in, people basically making claims one way or the other that it was safe or grossly unsafe. In the end, the authors retracted their conclusions and simply said, we don't know if it's safe or not in pregnancy. We simply don't know, and that more research is needed. I was leading a group with Canadian authorities, Deanna McLeod, and as well as Dr. Ray Stricker from University of California, San Francisco. Ray leads the largest fetal loss program in the United States, and we published our analysis in Trial Site News, and we concluded that for pregnancy, the COVID-19 vaccines are category X, meaning under no circumstances should they be used. X means don't use it because there is a dangerous mechanism of action, and we have great concerns. And I want to provide the exact citation for the only pregnancy paper. And the first author is Tom Shimabukuro, and the senior author is Dana Meany-Delman, and this is for the CDC VSafe COVID-19 pregnancy registry team. This paper, published in the New England Journal of Medicine, April 21st issue, in many ways is representative of the great confusion and the concern we have about vaccination in pregnant women. So I can tell you, as a doctor of, I'm in a position of authority in the United States to make this call. I'm telling your listeners, pregnancy category X, and it's off limits.
And you talked about in there how you've seen, pregnant women bouncing back from this and from COVID. I myself got COVID at the beginning of my pregnancy. Was fine afterward. Baby's on track, doing great. Can we make any conclusions yet on what sort of natural immunity I might pass along to the baby?
There are data suggesting you will pass along the antibodies against the spike protein in the nucleocapsid to the baby. But we don't know yet now whether or not the baby would immune. Now, remember, babies have little or no symptoms of COVID-19. It would be a runny nose that you wouldn't be able to detect anyway. So children don't have any significant symptoms with COVID-19. We know that from the registrational trials. We know in the paper by Walther and colleagues, New England Journal of Medicine, where they tested Pfizer 10 micrograms at baseline and then 10 micrograms 3 weeks later. And then in a paper by Frank and colleagues, New England Journal of Medicine, ages 12 to 17, where they used the full 30 micrograms dose of Pfizer. That's 4,500 patients in these two trials. Do you know there was less than 24 kids who got viral upper respiratory symptoms with COVID-19? And it wasn't 100% effective, but there was no spread, no mention of spread, no serious illness. It would be like, it's indistinguishable from one of the other 4 colds these kids have a year. Why would we vaccinate against one form of a cold, and not against another form? So you went back to the same thing. What are people getting at with vaccinating pregnant women of childbearing potential, and children? You know what I think? It doesn't sound good as a bad word, but it looks like they're using them as human shields. They're trying to actually vaccinate young people to somehow protect older people. And I think it's wrong. It doesn't feel right. We know that these pregnant women won't be helped. They're going to be harmed. The babies are potentially going to be harmed if the data suggests from that Shimbaruku paper that there's a high fetal loss rate. We're talking about unnecessary miscarriages, loss of human life. And And for children, we know it's off limits. And the FDA has told us that. The FDA has official warnings on Pfizer and Moderna. Do not use in children because of the risk of myocarditis. This can't be any more clear to mothers. In June of 2021, the CDC and FDA reviewed 200 cases of myocarditis. This is serious heart inflammation. It causes chest pain, signs and symptoms of heart failure, dramatic EKG changes, very high cardiac troponin, the blood test for heart injury, far higher than a heart attack, far higher than we ever see troponins in patients with COVID-19 in the hospital, respiratory illness. So we know the vaccine is really kind of a violent cardiac injury syndrome. 90% of these kids are hospitalized. And so I was on the national news in June. I said, wait a minute, this looks like this is the tip of the iceberg and it looks serious, very important. And I was right. So as we sit here today, we now have the most recent vaccine adverse event reporting system data, and it's just come in for the week ending December 3rd. And you'll be shocked to learn that the CDC now has verified 16,918 cases of myopericarditis. We anticipate, in an analysis by Rose and myself published in Current Problems in Cardiology, we anticipate that the peak is around age 17, but the tail goes all the way out to age 50. And men predominate. Pretty much about 90% of the cases are men. So here we have it. We have a large number of young individuals, and I'm talking 16,000 is large. In the prior studies of myocarditis, it'd be just a handful of cases. We should only have about 300 background cases per year of myocarditis due to parvovirus, or sometimes it's idiopathic. But we're sitting on 16,000 injured young people, seriously injured young people with the COVID-19 vaccines, where they have no opportunity for benefit, and they obviously are incurring great harm.
Well, as a mom, I thank you for, exposing that and for communicating that to people. And I want to be respectful of your time because I know you're busy and you've had a long day as a doctor. And so I just want to wrap it up because you've mentioned in there a few times, and I know you're a big, you really want to push the education on this for that there is treatment for COVID-19. So how would you move forward with what we should all do as a globe, really, to move forward in combating COVID-19 and any other variants that might pop up?
Right. So the treatment works for all variants. This is really important. The treatment works for all variants. And treatment really only needs to be applied to people who are at higher risk for hospitalization and death. Young people who get through it, just like they're going to get through any other cold, treatment isn't needed. So we're talking about 25% of the population would need treatment based on risk stratification. So we are largely talking about people over age 50 and then adding on medical problems like obesity, diabetes, heart disease, kidney disease, pulmonary disease, and age plays a big role. So as the higher the age gets, the more we get worried about COVID-19. So what we think is that everybody should have a home kit, a home prevention survival kit for COVID-19. COVID-19 should not be a surprise diagnosis right now, and nobody should be scrambling. Everybody should know what to do. So here's what should be in the kit. The first thing is oral and nasal virucidal washes. And so we know the virus is not spread by the hands. It's actually spread through the air. We breathe it in and the virus settles in our nose. We need to wash out our nose once or twice a day when we go out in congregate settings if we're still susceptible. How do we wash out the nose and kill the virus that settles in our nose? We use dilute povidone iodine, and that's a betadine. You buy it over the counter. I saw Amazon is $7, very inexpensive. It'll be more than what you need is a single bottle, 2 teaspoons, 6 ounces of water. Get a bulb syringe like you're going to use with your baby, or a nasal spray bottle. Spray up a lot in the nose, sniff it back, and then spit it out the mouth, and then gargle. That basically handles it. If it stings in there, it means it's too strong. Dilute it some more. If someone has iodine insensitivity, has hyperactive thyroid, or pregnant women, we think they should use a hydrogen peroxide approach and use dilute hydrogen peroxide, about the same dilution, add a couple of drops of Lugol's iodine, which is fine. And again, deep spray up the nose, and sniff it back and spit it out the mouth. And again, do that twice a day. That markedly cuts down transmission by about 75%. It's actually better than a vaccine. Doing oral nasal virucidal treatment is better than a vaccine. And then during the setting of acute treatment, we go every 4 hours. I have patients right now doing every 4 hours, and we markedly reduce the viral load in the nose and make it a milder syndrome. Randomized trial by Chowdhury and colleagues, 606 individuals, 303 in each group. It was night and day in terms of clearing the PCR and dropping rates of hospitalization or worse. What else should be in the kit? Nutraceuticals. We know that zinc plays a role. People on diuretics tend to be zinc deficient. We know vitamin D plays a huge role. 5,000 international units a day for baseline. We want to achieve a blood vitamin D level over 50. When that happens, we have virtually no COVID and no mortality from COVID. And then during acute treatment, we go up to 20,000 units a day. This is very important, 20,000 units a day. And we actually use that as a drug. Vitamin C, 3,000 milligrams only needed for acute treatment. And then quercetin or quercetin, 500 milligrams once a day prevention, 500 milligrams a day, twice a day for treatment. The last thing I'd bring into that shoebox for prevention would be an over-the-counter drug that's an antihistamine antacid called Pepcid or famotidine. And that would be 80 milligrams a day of famotidine for acute treatment. That survival kit will get so many people off on a good start. And I can tell you with COVID-19, if I've learned anything in the last 2 years, is start early. When it's a very mild, drippy nose, that's when you should be hitting it very hard with this approach. And then we can move into the other drugs. Everybody over 65 and those over age 50 who've got medical problems know where your monoclonal antibody center is. Make some phone calls now. Figure out where the centers are in your county, in your community. Where do the infusions give? And do you need a doctor's order, or is it first come, first served? Do you get scheduled? Everybody should write down the address and a phone number. We should not be scrambling for monoclonal antibodies anymore. We're 2 years into this. These are fully FDA approved. They work. They're like miracle drugs. When I talked to Joe Rogan this week, he said it was clear the monoclonal antibody made a huge difference. I do this every day in my clinical practice, and I tell you, they're underutilized. They're underutilized. They're grossly underutilized. We have more than enough monoclonal antibodies. They're provided by the government. People should seek them out. If we can't get monoclonal antibodies, then we go in and use oral drugs. We use hydroxychloroquine supported by 300 studies, or ivermectin supported by over 60 studies, combined with azithromycin or doxycycline. We use inhaled budesonide throughout. We use colchicine throughout, aspirin throughout. People get sicker. We use oral prednisone about day 5 or pulmonary symptoms. High-risk patients, seniors, people in nursing facilities, we'll put them on Lovenox injections as blood thinners or oral anticoagulants. In total, it takes about 4 to 6 drugs to get somebody through COVID-19. We can stylize it for their background medical problems. Skilled doctors can do this. A short course of treatment for maybe somebody young like you with severe symptoms would be 5 days. Average person my age, 10 days. And then seniors plan for 30 days of treatment. This is called sequential multi-drug therapy for COVID-19. It's enormously successful. Even with our very first combinations, we had 85% reductions in hospitalization and death. Add in the monoclonal antibodies. Everybody ought to be like former President Trump or Governor Abbott here in Texas, or Joe Rogan or Aaron Rodgers. They breeze through the illness. They breeze through the illness. No one should suffer with COVID-19 if they get high quality care. Every patient should call their doctor and say, listen, are you ready to go? These are simple drugs. Do you know how to prescribe them? Do you have the treatment protocols? Do you have the treatment guides to do this? They're available through the Association of American Physicians and Surgeons, American Frontline Doctors. The Frontline Critical Care Consortium has a slightly different protocol. That's fine. These ideas converged over the last year, and the Truth for Health Foundation. But this is very important. Early treatment reduces these illness, because someone's infectious for 14 days with no treatment. We can shorten that down to 4 days with early treatment. This is night and day. Early treatment closes out the pandemic. That's what happened in Mexico City. That's what happened in India. It's happened all over the world, that when we finally lock in on early treatment, we can end this.
Well, thank you so much for educating people and for being an advocate for that and treating people in your own practice with this. So we just really appreciate all that you do. Where can people follow you on social media and online?
You can follow me on America Out Loud Talk Radio, the McCullough Report. That's really kind of the academic update that I provide the country. And it's fun. I have a music segment now where there's music that's been spurred on by the pandemic crisis. Eric Clapton reached out to me, helped me start that. He was one of the first ones to have a music segment. So I just turned in my report this week, and I've a music segment for someone in Australia. Wonderful piece. And I bring on experts. This week I brought on Dr. Paul Merrick of the Frontline Critical Care Consortium. He's considered the father of modern critical care. What a treat to have him on. But it's not just me. I bring on experts from all over the world, largely doctors or medical people, sometimes people of other occupations that can give us key insights on what's going on. I mean, that's what America wants right now. America wants the truth. They want scientific truth. They feel like they're not getting it on the major media. So they're seeking out programs like yours and America Out Loud Talk Radio, the McCullough Report.
That is so correct. That is so right. And we are so grateful to you for helping us with that. And it was a treat to have you on our podcast. So thank you so much, Dr. McCullough.
Thank you.
What a treat to have Dr. Peter McCullough on the program. He told me that he's not really dove into pregnancy and COVID-19, pregnancy and the COVID-19 vaccinations much on air. So you kind of heard some exclusive information there from Dr. McCullough. And he has been all over the airwaves, on Joe Rogan's podcast, everywhere, on Fox News, all the major media outlets. So to have him give us some exclusive information and knowledge is great. And that is what he's all about, is sharing the truth. That is what one of the missions of We the Patriots USA is education and sharing the truth and informing people what they need to know. So head over to wethepatriotsusa.org to join that mission. And we just want to continue to encourage you all. Remember what I always say, faith and freedom over fear.